Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even fewer are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, and welcome to VITALS. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and we are pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. VITALS is an open forum to hear from today's national leaders who are transforming the healthcare landscape using the VITALS tools: value, innovation, technology, advocacy, leadership, and service. Today, we are honored to welcome one of our own to VITALS, 1991 College of Medicine alumna, Dr. Theresa Michelle. Dr. Michelle is director of the Office of Nonprescription Drugs in the Office of New Drugs, Center of Drug Evaluation and Research at the U.S. Food and Drug Administration. Among other drugs, the Office of Nonprescription Drugs is responsible for regulating healthcare and consumer antiseptics. Prior to joining the FDA in the Division of Pulmonary and Allergy Drug Products, Dr. Michelle spent 10 years in industry with clinical research experience across a variety of therapeutic areas in both commercial and development stage companies. She is board certified in internal medicine, pulmonary medicine, and critical care medicine, completing her training at Johns Hopkins University, where she currently serves on the faculty. Please welcome Dr. Michelle to VITALS.
So thank you, Dr. Langell, for such a kind introduction. As an alumna, it's just such an honor to come back to my roots and be asked to speak to students in the greater NeoMed community. And it truly is a community, which from my experience here and elsewhere is one of the greatest strengths of NeoMed. All of the community health professionals, in addition to dedicated faculty who spend so much time and energy educating and mentoring NeoMed students. So first off, let me say thank you to all of you who have helped so many of us go on to wonderful medical careers, so that hopefully in some small way we can pass on the benefits that we have received to our patients and to our communities. So in my case, I'm really privileged to serve as a medical officer at FDA, which is a place where I can put to work the lessons that I learned from NeoMed about collaboration across the healthcare community and the essential nature of having excellent communication skills and the ability to listen to patients. So in the Office of Nonprescription Drugs, we essentially get to serve as the doctors for the entire nation, since the drug products that we regulate are sold directly to consumers. We're really not only responsible for ensuring the safety and efficacy of the drugs that people use every day, but also of making sure that consumers can understand the information necessary to do so. Now, before moving on to speak about drug regulation, I do need to highlight the disclaimer that the opinions and information in this presentation are my own and do not necessarily reflect the views and policies of the FDA. So the U.S. Food and Drug Administration has more than 18,000 employees across all 50 states and internationally to assure the safety and efficacy of human and veterinary medicines, biologics, and medical devices. We also regulate the safety of food, cosmetics, devices that emit radiation, and tobacco products. Together, these products account for a large portion of the US economy. And in fact, FDA-regulated products account for about 20 cents of every dollar spent by US consumers. Today, I'm going to focus on non-prescription drugs, which fall under CDER, which is the Center for Drug Evaluation and Research. Now, before I jump into where I see the future of the non-prescription drug market, I'll pause for a moment and make sure we're all on the same page of what a non-prescription drug is. Next slide. There are two kinds of drugs in the US, prescription drugs and non-prescription drugs, which are sometimes called over-the-counter or OTC drugs. So when's a drug considered prescription? Well, if it is not safe for use except under the supervision of a healthcare practitioner, and usually this is because of toxicity or other harmful effects, method of use, or other collateral measures like required monitoring. A drug can be non-prescription if it doesn't meet any of those criteria for prescription-only dispensing, and they can be used by a consumer without the supervision of a healthcare practitioner. Now, non-prescription drugs have long provided an efficient, low-cost way for Americans to take care of everyday health needs without having to visit a doctor and obtain a prescription. They include things like drugs for allergies, pain, fever, and many others, as well as things that you might not think about as drugs, like fluoride toothpaste and other dental products, sunscreens and antiseptics, including hand sanitizer and surgical preoperative preparations. They can be purchased in many online and retail outlets, including pharmacies, grocery stores, and convenience stores. Now, I'm sure it will come as no surprise to any of you that the consumer marketplace is fast moving. And this phenomenon was greatly accelerated by the pandemic, which further pushed the move from the majority of sales in brick and mortar stores to significant online sales and advertising. Next slide. With all of the new technologies available to consumers, it's important that we also reimagine what the future of non-prescription drugs will look like. So I put this slide together a few years ago to start doing just that. Ask the questions of what we could do to help improve non-prescription drugs and provide additional options for consumers. So I asked the question of, how can the delivery of information for correct self-selection and use by consumers be improved? And self-selection means the actual process of reading the label and deciding, is this drug right for me and my condition? How can technology impact that and expand the availability of certain drug products? And finally, how can the regulatory process support safety and innovation while also being more agile, timely, and predictable? So I'll spend the rest of this presentation giving some examples of things that we have done in these areas and the impact that this can have for consumers and for patients. Next slide. So first off, how can the delivery of information for correct self-selection and use be improved? Now, in order to answer this question, you first need to ask, how is this information typically delivered to consumers now? Next slide. So currently, non-prescription drugs have to be labeled with adequate directions for use so that the consumer can appropriately self-select and use them on their own. Now, for over 25 years, this has included having a drug facts label or a DFL, which is shown on the right-hand side of this slide. And you can see how much information needs to fit in this very small label, which for certain drug products is quite limiting because it presents challenges for adequately communicating all of the information that consumers need to know. So we encourage use of other types of labeling, such as package inserts and websites. Next slide. One example where novel labeling really made a difference was in the approval of non-prescription naloxone, which we first approved as a switch from prescription to non-prescription to treat opioid overdose in March of 2023. And it first hit consumer shelves in August of that year. So in the years since naloxone became available OTC, opioid overdose deaths have decreased for the first time since 2018. And we are, in fact, now seeing the largest decrease in overdose deaths on record, which is particularly seen in Ohio. Typically, manufacturers are responsible for initiating and doing the research to support the safety and efficacy of a switch of a drug from prescription to non-prescription status. Now, in this case, the manufacturers told us this is too difficult to translate the prescribing information for physicians into steps that an untrained bystander could understand in a crisis situation where the overdose victim was not breathing. So we decided to take this on ourselves, and we took the initial steps of developing and testing a model drug facts label. To do this, we created novel labeling, which we tested in over 700 adults and adolescent subjects, including 430 adults who used opioids and their families and friends. This study was published in the New England Journal, and the full study report and the model DFL was posted on the FDA website for manufacturers to use in their development programs. Next slide. So just to give everybody a visual of what this looked like, here's the 13-page physician prescribing information that we started with. And you can imagine this is not very helpful to a consumer in an emergency. Next slide. And this is the model drug facts label that FDA designed and tested. What's really unique about this label is not only are the directions broken down into very simple and easy to follow steps, but it also includes simple pictograms just outside of the DFL that I've highlighted here in red that illustrate the steps. Next slide. And finally, here's the commercialized approved product label where the manufacturer utilized the FDA model DFL as part of their marketing application. Next slide. Now, but what about prescription products that are very safe and effective in the right population, but there's either too much or too complex information for labeling alone to ensure that a consumer can appropriately self-select and use the product without a healthcare practitioner? So we asked the question, can technology help? Next slide. I am very excited to be able to tell you that just 2 weeks ago, FDA published a final rule that allows the use of labeling in combination with an additional condition of non-prescription use, and the acronym for that is ACNU, to ensure that consumers can effectively self-select and use the drug product without healthcare practitioner oversight. Okay, sounds very dry, very boring, but what does it mean for a consumer? So for a non-prescription drug with an ACNU, the consumer will have to complete an extra step, generally involving technology, like complete a questionnaire on an app or a website to see if the drug is safe for them. The consumer will be unable to purchase the drug without completing the ACNU. The rule is intended to increase options for drug companies to develop and market safe and effective non-prescription drugs. And this can really benefit public health by increasing innovation in the non-prescription development space, providing greater access to drugs and flexibility for consumers. And it may help address health equity by lowering barriers to access, particularly in areas where a physician is hard to come by. So since the rule just came out, there are currently no approved non-prescription drugs with an ACNU. But stay tuned, I expect that over the coming years, this could really lead to many more options for consumers. Next slide. And finally, how can the drug regulatory process be improved to support safety and innovation, while also being more agile, timely, and predictable? Before I start to answer that question, I'll digress just for a moment and explain what the regulatory process is that we're trying to improve. Next slide. So there are two ways to bring a non-prescription drug to market in the US, and most people don't know this. The new drug application and abbreviated new drug application process, and the OTC drug monograph process. Everything that we've talked about so far are drugs that have been approved via the NDA process. Under the NDA process, which is also how prescription drugs come to market, an application to the drug for the drug is submitted to FDA for approval. The application includes information about the safety and effectiveness of the drug, and the drug can't be marketed until FDA approves that application. The NDA is also specific for a particular drug product, including its formulation, its dose, its use, and its labeling. In contrast, an OTC monograph drug can be marketed without FDA approval if the drug complies with the requirements in the Act, as well as applicable conditions of its therapeutic category-specific OTC monograph. Okay, that's a mouthful. What does that mean? So next slide. So what is a monograph? Well, think of it as kind of a rule book. It's conditions for each therapeutic category that describes the active ingredients, the uses, the doses, the route of administration, the labeling, and the testing for an OTC drug to be considered generally recognized as safe and effective, or GRACE. Drugs that are GRACE and meet the other requirements can be marketed without a new drug application and FDA pre-market approval. The monograph system remains one of the largest and most complex regulatory programs that have ever been undertaken at FDA. It currently covers more than 100,000 different OTC drug products, and these monographs or rule books cover about 800 active ingredients for more than 1,400 different uses. And I would bet that you all probably have one or more monograph drugs in your medicine cabinet right now and don't even know it. Things like acetaminophen or aspirin, antacids, fluoride toothpaste, antiperspirants, antiseptics, sunscreens, and a whole lot more. Next slide. OTC monograph reform was enacted by Congress in 2020 as part of the CARES Act. So it significantly modernized the OTC drug review system by replacing the rulemaking process with an administrative order process that gives FDA the authority to issue an administrative order that adds, removes, or changes GRACE conditions for an OTC monograph. It also established an expedited process to address urgent safety issues and gave industry a streamlined pathway to innovation. These changes addressed serious process weaknesses under the former OTC drug review to reduce regulatory burdens, encourage innovation, increase efficiency, and streamline safety updates. Now, whenever new legislation is passed, there's a lot to do to set up the infrastructure necessary to implement the program. And so far, FDA has been very successful in meeting our implementation timelines, and we're starting to move forward to update monographs. So again, coming back to that question, what does this mean for the consumer? Well, one example of what we've been able to do under the new process, next slide. This past November, we issued an order that proposes to remove oral phenylephrine as a nasal decongestant from the monograph because it is not effective. Currently, oral phenylephrine is widely used as a nasal decongestant active ingredient in many OTC monograph drug products. Now, for now, companies may continue to market OTC monograph drug products containing oral phenylephrine as a nasal decongestant until a final order is issued. Before we issued this order, we conducted a comprehensive review of all available data on the safety and efficacy of oral phenylephrine, including historical data that were used to support the determination made 30 years ago that oral phenylephrine was effective as a nasal decongestant, as well as newer data on oral phenylephrine that have since become available. Before making the decision, we held an advisory committee meeting on this issue, and we informed the public of our intent to publish this order in the annual monograph forecast. The comment period is currently open for the order, and we'll consider the public comments received before issuing a final order. Next slide. So I'll just end with a few additional resources for you about the subjects I discussed. And I thank you all for your attention, and I'm very happy to take any questions.
Thank you so much, Dr. Michelle. That was such an informative presentation. And I know from a consumer standpoint, a lot of people are going to have additional questions. So I just wanted to throw some out. The last thing you were talking about was phenylephrine. You know, when that news came out that the FDA was saying that it was ineffective, a lot of people wanted to know, is it even safe to use?
So that's a really good question. And also one of the things that we looked at was, what's the safety of phenylephrine? And even though it's widely used, we identified very few cases of serious safety issues when it's used as directed according to the product label. So if your drug product has oral phenylephrine in it, you may continue to use it. And many of these drugs are combination products. So the addition of phenylephrine to the product does not affect how the other ingredients like acetaminophen work in those products.
So does it have any use whatsoever, or is it just something that should be taken out of medications, period?
Well, oral phenylephrine, the problem is that it is broken down by the gut. So it actually, not enough of it gets in the bloodstream to affect the congestion in your nose. It is effective when administered via other routes. So there are nasal spray products with phenylephrine, and a much higher concentration gets to the site of action in those cases.
Let's talk about acne. How will a consumer know that a non-prescription drug has an acne? What do they look for?
That's also a very good question. So you'll know that a non-prescription drug has an acne because the front and back of the label will have information about the acne on it. So there will be a statement on the front of the package to alert consumers that the non-prescription drug has an acne, which may read something along the lines of, you must complete an extra step to see if this drug is safe for you before you use it. And do not take the drug without completing this step. And then you should see the drug facts label, which is usually on the back of the package, for additional information. This is important because even though a consumer has to complete the acne before they purchase it, then it's sitting at home in their medicine cabinet. And we want to make sure that everyone else who sees that product knows that they shouldn't be taking it unless they've completed that extra step.
Let me throw this out at you. How long before the industry has to change or remove products containing oral phenylephrine from the market? And also, how long before they have to add the acne?
Okay, so those are two separate things, and I'm going to kind of pull them apart a little bit for you. So acne is a separate process. It has nothing to do with phenylephrine. And acne is an opportunity. So it gives industry a way that they can bring novel products to the market that maybe couldn't make it over that hurdle with just labeling alone. So it's not something that's required of industry. It's something that is an opportunity, and an opportunity for consumers when those products eventually make it to market. Phenylephrine is a different case. In that case, phenylephrine is already widely marketed. It can continue to stay on the market until FDA issues a final order. Now, in the meantime, pharmacies may choose to remove some products which contain oral phenylephrine as an active ingredient from store shelves, even though FDA is not requesting that pharmacies do this. Currently, the proposed order is just the first step in the process that FDA would take to finalize its determination that oral phenylephrine is not effective. So again, right now, these products can continue to be marketed. The order's open for 180 days for public comment, and that goes until May 7th. And after we consider the comments, if we conclude that it's still not effective, we will issue a final order removing it from the market. And that's when it would no longer be allowed to be marketed. We would also give manufacturers appropriate time to either reformulate their products or remove those products from the market.
I'm glad you brought up public comment. How important is it for people to share their experiences and discuss things with the FDA, and how do they do so?
So it's very easy. We have a one-stop shop for all things monograph. And in fact, you can go to our website on OTC monographs at FDA. You can view the orders. You can view all of the information that we looked at as part of this and see instructions for exactly how to comment there. And we welcome public comment, particularly from the medical community. It's very important. In fact, public comment sort of started off this process with oral phenylephrine. There was a citizens petition from some pharmacists in Florida asking about it.
Why did the OTC drug review need to be reformed?
Well, it's perhaps useful to think about why did the OTC drug review go into place to begin with? And it was set up more than 50 years ago. And this was when the Kefauver-Harris Amendment to the Food and Drug Act was passed. Prior to that, FDA only had to look at the safety of drugs. This amendment said FDA should also evaluate the efficacy of drugs. And for new drugs going forward, the new drug application process was put in place. But what about all these drugs already on the market? So there were several 100,000 OTC drug products on the market at the time, and we just couldn't look at each one individually. So the monograph system was set up using a three-step federal rulemaking process to address each therapeutic category. And at the time, we thought that because these were old drugs, science wasn't going to change, and it was originally conceived as sort of a once and done kind of process. But of course, we know that's not how things turn out. We're constantly learning new things, and there's a lot of innovation. So despite our successes in providing consumers with access to a wide variety of safe and effective drugs, as time progressed, challenges for this 50-year-old process became apparent, particularly as the federal rulemaking process became more complex. So we had these burdensome multi-step rulemakings. We didn't have adequate resources. We had delays in finalizing things. There was basically minimal process for innovation. Safety issues were delayed, and we just couldn't keep up with the science. So now we have a much better process for doing so. And we are able to address safety issues like add a warning to acetaminophen. That was something that had taken years before, and now we can do it in a relatively short period of time.
In addition to creating and testing a model drug facts label for naloxone, what are some of the other steps that the FDA took to broaden the access to get that medication?
Yeah, I'm sure I don't have to tell this audience that the overdose crisis is just, one of the most devastating public health crises affecting our country. And to address this evolving crisis, back in August of 2022, we announced our overdose prevention framework which is the FDA vision to undertake impactful and creative actions to help prevent overdoses and reduce deaths. And one of the 4 priorities is encouraging harm reduction. So that includes efforts like naloxone. In 2022, we also took one of the actions of issuing a Federal Register notice stating our opinion that the safety and effectiveness of certain naloxone products for non-prescription use and our preliminary assessment that these could be approvable non-prescription. And by issuing this notice, we sought to make the application holders aware that there was this pathway that they could submit an application and they could use the model drug facts label. And since that time, in addition to approval of Narcan, we've also approved a 3 milligram naloxone nasal spray, which was developed as a direct to non-prescription product, as well as several different generic products to the 4 milligram nasal spray.
What advice do you have for any doctors or healthcare professionals who might want to consider a career getting into the FDA? What do they have to keep in mind and what do they have to do?
So first off, FDA is one of the best kept secrets in medicine. It's a terrific place to work. And we have a multidisciplinary approach to drug review. So in addition to physicians of all specialties, we also hire pharmacists, dentists, statisticians, chemists, biologists, pharmacologists, toxicologists, social scientists, and lawyers, and that's just a few of them. So for physicians, we're really looking for people with clinical experience in a field and a research background of either basic science or clinical trial experience is also helpful, although it's not absolutely required. I'd also note that for students, we sponsor a number of postdoctoral research fellowships through the ORISE program, and we have other opportunities for students, including pharmacy students. So I would encourage people to look for open positions at FDA via the USA Jobs website or through advertisements in professional journals and specialty society meetings.
When you graduated from Neomed, was the FDA on your radar right away or?
No, actually it wasn't. So I went and started off with an internal medicine residency at Johns Hopkins and then progressed to a pulmonary fellowship there. And when I finished my pulmonary fellowship, I did some additional research time in the lab and I thought, oh, well, I'm going to be an academic researcher. And then I got a call kind of out of the clear blue sky from Merck, which is, is a pharmaceutical company. And I went on this interview, not because I thought I was going to take this job, but because I didn't know anything about it. And I'm a curious kind of person and I wanted to learn about it. And then I got there and I was like, wow, this is kind of cool. And so I ended up doing 10 years in the pharmaceutical industry before moving to FDA.
In your role, everything you do has an impact on the American public, and especially anyone who has something in their medicine cabinet and uses an over-the-counter drug. Can you expand on some of the outcomes that you feel had the greatest impact on improving the health of the American people?
Sure. So I hit on a couple of them today, but we've also had many others. We approved the first oral contraceptive over the counter. And I know that has had a big impact on the reproductive health for a lot of young women to make that available. We have had a number of safety changes. For example, we have worked to reduce the use of benzocaine oral products for infants, which can cause methemoglobinemia and led to infant deaths. We worked on hand sanitizers during the pandemic to make those more widely available to consumers and to the healthcare systems. So there are many, many things that we end up doing on a day-to-day basis. And it's exciting to think that, yes, we worked on this product and now here it is on shelves in a pharmacy where you can actually see the impact.
The FDA is such a massive government entity. From your experience for efficiency, for streamlining, would it help to separate food from drug and other things, or do you think the way things are set up work just fine?
So that's probably a little bit out of my bailiwick. I will note that the foods program has just undergone a major reorganization to make it more efficient. And I encourage people who are interested in learning more about the new innovations under the foods program to see our website and see what's going on in this space, which is very active right now.
Talk about your leadership journey and what you feel that would be helpful to those in the field of healthcare and those graduating, aspects that they should focus a little more heavily on.
Yeah, so I've always believed strongly that one should bloom where you're planted and always look for opportunities to take that next step and learn more. So I would encourage people to always be curious and always see what can I do to help more. And that's really has led me through my journey of what that next step is.
Dr. Michelle, any final thoughts today?
So once again, it's just such a privilege to talk to the NeoMed community. And I hope that our NeoMed students will think about careers at FDA and in public health because it's really incredibly rewarding.
Dr. Michelle, thank you so much. I'm going to hand it back over to Dr. Langell.
Thank you, Dr. Michelle, for sharing your thoughtful insights with us today. And thank you to our audience for joining us for today's special program. Join us next month for Vitals on February 6th, when we will welcome Dr. Shishabor, President of the Harrington Heart and Vascular Institute at University Hospitals.
This is Vitals, Visionary Health Leadership in Action.